Today we discuss management of post-operative complications in a patient who undergone bilateral lung transplantation. In the immediate post-op period, the patient had a severe PGD, grade 3, a primary graft dysfunction, and then on imaging he has a large cavity consolidation, bacterial infection, and then continues to have like an air leak bubbling in the tube with severe subcutaneous emphysema, as you can see on this X-ray. And on the drain you can see like a continuous air bubbling, and then we were called to close the leak because post lung transplant is a bit risky. Again, the other options we have here is to re-explore, and then we had a discussion with the surgeon, and then they initially asked us to close the leak using bronchoscopic methods, and then see if it fails, then consider surgical repair. So what we considered here is like we were able to identify the leak to the B6 segment on the left side. You see the anastomotic line is clear. However, there is a massive cavity like thing in the superior segment, and then that's where the leak is mainly from. And then we put a Watanabe spigot in the RB6, and then following the spigot we also try to secure the spigot with using glue, using a guide sheath of the radial EBUS probe. We install glue around the spigot and then try to secure the spigot in the initial days, because there is always a tendency that spigots might displace. So, as you can see here, never the glue can be put very locally. Sometimes there is a spillage like in this case, but we make sure like we wait for some time until the glue gets settled around the spigot, and then we do a bronch. Be careful not to get the tip of the bronchoscope glued. So, we always use a dextrose solution, and then as we go in immediately after the placement, you can see the spigot is tightly plugged into the BC segment, and you can also see the lower lobe basal segments. And then after a few minutes we go to clear the excess glue that is settling down in the lower lobe segments. It takes some time for the glue to settle down, and then using a forceps, once it crusts, we gently remove the excess glue. And then clear the airway. And slowly try to clear the excess glue that settled around the area. And once we clean, you can see the glue only around the B6 segment, and eventually the patient improved well. Gradually the surgeons were able to remove the tubes and then were able to discharge this patient. So,